Good morning, and I would like to welcome everyone who is present in the chamber and all those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would like to add, for those of us that are in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent and to try and ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep these succinct and concise. However, I will close down the debate to ensure we keep to time if needed, and would ask you indicate early to guarantee your question. As the meeting is being streamed in the usual way, I would like to remind you that all your comments will remain accessible online, as the meeting recording remains on the Council's website. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We received apologies for absence from Councillor Allen, Councillor Cleaver, and we have Councillor Dilts as his replacement member, Councillor Lucille Higgs, Councillor Glynis Scalesi, and we have Councillor Gurney as her replacement member. Thank you, Chairman.
Thank you. And I'd just like to welcome Councillor Dilts to the meeting, and Councillor Gurney, nice to see you back, and also to welcome our new member, Councillor Gee, so welcome. We'll now move into agenda item 2, declarations of members' interest. This is an opportunity for the members of the committee to declare any pecuniary interests or other interest. Do members have any interest to declare at this point? Councillor Kendrick, please.
Thanks, Chair. My usual declaration, I'm a Partnership Governor of Lincolnshire Partnership NHS Foundation Trust.
Okay, thank you. No further, we'll move on to agenda item 3. This is to confirm the minutes of the meeting held on the 21st of February 2024 as a correct record. They are found on pages 3 to 13 of the agenda pack, and as the committee has had the opportunity to read these in advance, I plan on taking these on block. Do I have a proposer for these? Councillor Smith, thank you. Seconded. Thank you. Councillor Wootton. All those in favour, please show. Abstentions? Thank you, Councillor Dilts. They are carried then, in which case, thank you. We'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda, and supplementary announcements were circulated on the 19th of March. Does anyone have any questions on my announcements? Councillor Smith, please.
Thank you, Chairman. The decision around the Humber Acute Services Review, as you've put in your announcements, Chairman, is quite frankly very damning and reiterates the discussion we had at our last meeting. And I'm sure you and Councillor Bonney, who were on the meeting and the working group, look forward to keeping a close eye on these to ensure that the needs of our residents here in Lincolnshire are actually met through that review process. With respect to the reply we have received from the Home Office with regard to the provision of health services at RAF Scampton, if the Home Office proposals go through, it's staggering what provision will be, what the provision will be that isn't available to and hasn't ever been available to local residents. And also, Chairman, the fact that the Home Office don't have any data on the strain of such a site on LPFT or other partners in the country is quite frankly staggering, because they'll sit there and say, oh no, this will cause no strain, but you've got no data and no evidence to back it up, Chairman. So I can't say I'm surprised at the reply, but for them not to have any data when they've been doing this for a long time in Westfield and other places is frankly staggering.
I said, well, we know about it, but we don't know what it is. It's got to be something.
Not sure who's coming through where. Got it. Thank you, Simon. Okay. Thank you, Councillor Smith. Yeah, absolutely. Well, Scampton will obviously keep a close watching eye on, and I think we have said quite a lot about the Humber Acute Review and how poor it's been, so I'll leave it there. Thank you. Any other comments on my chairman's announcements? Councillor Mackinson-Saunders.
Thank you. The government blood pressure campaign is working. I was offered a test on Saturday morning, so it's up and running, even in the sticks.
That's reassuring. Thank you, Councillor Mackinson-Saunders. Councillor Morgan, please.
Thank you. Can I just clarify regarding the information from the East Midlands Ambulance Service? I can see what we've got here, but I thought, and forgive me, it might be somewhere else, but I thought we were also waiting for them to, because they didn't actually give us what the category level 1 stats were at all, their performance figures. And the other thing was waiting for their stats regarding the number of ambulances stopping off at Grantham Urgent Treatment Centre, the enhanced centre. They're not on here. I'm wondering if perhaps it's because it's a different area, they're covered elsewhere. Thank you.
We've chased them. We haven't received them as of yet, so we are still waiting for that response. But it's more than once now we've got onto them, so we'll try again. And failing that, we'll probably go up and speak to Richard Henderson and see what he's got to say, really, and try and get that response brought forward. So thank you, Councillor Morgan. Any other comments on the announcements, please? No, in which case do I have a proposer that these are noted? Thank you, Councillor Mackinson-Saunders. Seconded. Councillor Kendrick, and all those in favour, please show. Thank you. They're noted. In which case, we'll now move into agenda item 5, the Lincolnshire Partnership NHS Foundation Trust update. This item was circulated as part of the agenda pack on pages 19 to 27. This item was requested by the committee on the 21st of February in response to some developments being reported, including progress with removing Legionella from the Heart of Same Centre and the expansion of the Adult Eating Disorder Support Service. I'd like to welcome in person Chris Higgins, Director of Operations for Lincolnshire Partnership NHS Foundation Trust, and Joe Walker, Head of Communication and Participation, who's here observing. If I could hand over to you just for a presentation for about 5-10 minutes, and then we'll take questions at the end. Thank you, Chris.
No problem. Thank you very much. Thanks for having us here. So just, you've obviously got the paper. I won't go into a huge amount of detail, but just drawing out some high-level points. Firstly, on a couple of temporary service changes that have been underway. One is the Heart Centre we've talked about previously. The committee will be aware that that unit's been temporarily closed for some time. And at the point of a reopening, we discovered high levels of Legionella that meant we couldn't reopen as planned. We've been doing a lot of work on that to flush the system. Won't go into technical details, but get us into a position where we're looking to reopen again. At the moment, we're aiming towards May. We think we'll have clean Legionella results confirmed in April. That will, after a couple of weeks of mobilisation, we'll be positioned to open in May. That is dependent upon those next set of results coming through in the way that we hoped, but all the staff's in place. Obviously, that was the original issue when we originally closed back in the October of 22. But that's all in place, ready to go. The team's all prepped. So as soon as we get the all clear, we'll be on track to open. The second one is around Manthorpe Centre, Manthorpe Ward at Grantham, which is was a dementia unit closed some time ago, as the committee will be aware. There's been quite a long process of getting us to where we are today, but as previously agreed with the committee, we've been doing a formal pilot of that new home treatment service over the last year, and we've, again, from agreement with the committee, we've engaged the East Midlands Clinical Centre, who've been really active in helping us evaluate that service. So we're hoping to conclude that in the summer and bring something back in September time that will be able to set out a proposed way forward for that service. In terms of just, I wanted to highlight a particular challenge we've got in mental health services, both here in Lincolnshire and nationally, is what appears to be a change in profile of need, particularly amongst our female patients in the most complex settings, our acute and PQ settings. We've got a number of patients that whose needs seem to have changed over time, or there's certainly a greater proportion of people with this set of complex needs that often is serious mental health problems, personality issues, personality disorders, combined with other eating issues and different things, which makes it quite a complex set of needs to meet. Whilst they're not new presentations, the number of people and the proportion of people coming through that level of complexity is new. And that's forcing us to have a look differently about the services we're currently providing. It's been felt most keenly on our long-term rehab, our high dependency rehab ward, the Vales, that's detailed in the paper there, and we're doing a piece of work just to re-look at the staffing profiles and re-look at the training for staff to make sure we can adequately meet their needs. What I would say is that's forced us to look more broadly than that across the whole pathway for female patients in that acute inpatient setting. And we know that we don't provide female PQ locally. So again, we're using the opportunity to look at that and consider what options we might have using our existing resources in county. So as that work progresses, I'm happy to bring some further updates as we know more. We're just flagging a couple of services that are coming online, some new developments. NHS 111 is changing so that in the future, as of next month, people of the community be able to press 111 and press 2 and option 2 to be able to contact local mental health services. There's a complicated technological solution behind it which basically routes people's calls to the local provider. We've mobilised a team in preparation for that so that we can accept those calls, but we're still working with NHS England around some of the technical capability for launch, but you should start to see a bit more information about that in the next coming weeks and months. The idea being that people in any kind of mental health crisis or distress can ring 111 and get to a specialist mental health provider rather than the generic service that's currently provided. Another development is the Autism Hub, or the virtual Autism Hub. This was a bit of money that we worked with our local integrated care board to commission a relatively small but high impact service. So it's designed with a number, about 4 autism specialist navigators that provide a virtual support so that people with autism needs can contact and get signposted into services and support to access mainstream and other services. Alongside that, there's a grant scheme of around £150,000 a year, and that the team allocate out. And at the moment, we've got about, I think the number of grants being allocated about 17, so about 120k of that 150. We've got 17 grants allocated and across 11 different organisations. And hopefully in time, that resource and support for people with autism will grow, and our navigators will be able to point people in the right direction. What I would say, it's something that we hope in time that this is maybe not a service that LPFT delivers. It's a non-clinical service. It could be delivered by other partners, third sector organisations, and we hope as other organisations come to the fore, it's something that they may be in a better position to expand and grow better than a traditional NHS provider. But for now, we're happy to provide it to get it off the ground and make sure it's delivering good quality services for the people of Lincolnshire. Eating disorders was something the committee was particularly interested in. Traditionally, in eating disorder services, the team's been a specialist team supporting those people who've been identified as having a moderate to severe need, and anybody with low to moderate needs have been taken care by of our kind of talking therapy services, previously known as IAPT. A piece of work that's been underway is to transform that service so that it provides specialist support across the whole range of need, so that team will start to accept referrals in for people, anybody over the age of 16, regardless of the level of complexity, and adapt the need and treatment accordingly. So that's been piloted in a couple of PCN areas first. I think the council will be aware of the PCN geography, but there's 2 PCNs that will be starting in, that's the primary care networks, and then over the course of the next 12 months we'll evolve that and expand it out to the whole county. So really good development. It means more specialist support for people at that lower end, hopefully preventing from people's conditions worsening as time goes by. Just want to give a nod to recruitment and retention. Obviously that's been an issue that we've brought back on a number of occasions to the committee. The recruitment continues to be a significant challenge for LPFT and other providers in the NHS. However, we've had some really good progress over the last year or so. PQ being a great example of that, where we were unfortunately forced to close services because we didn't have enough staff to run them all. We're now reopening services because we're in a much more stable staffing position. So it was a long way to go. There's still lots to do, and there's still some hotspots in services that are causing particular challenges, but on the whole, it's a much better position to be in than we've been previously, and we'll continue hopefully on that trajectory. I won't go into all the waiting times information. You've got it there. Obviously, it's good news. Still, again, more work to do, but across the board heading in the right direction, and hopefully you can see that there's some measures we're taking to make sure things are improving for everybody across those different pathways. The other thing I would identify is around memory assessments. We know that Lincolnshire is slightly different in terms of we haven't got a dedicated memory assessment service where other counties have. We've used our own existing mental health services for older people to be able to provide that memory assessment service. And we're working with our commissioners to see if there's a way of funding that differently and setting it up differently so that we can provide a really dedicated support, because we know that early diagnosis is really important. But that's still work in progress, but hopefully an improvement we'll see in the months and years to come. So I'll stop there, but happy to take any questions.
Thank you, Chris. First question comes from Councillor Wood, please.
Thank you for your report, Chris. It's really good to see the expansion of NHS 111. I was just wondering if the telephone number will be available for family, friends and professionals to use, as well as the person in crisis. Will support be available in circumstances where an individual is not already open to services locally, or if they have a pre-existing condition? And will the referral route have an option for a medical professional to attend if needed? And then just on the virtual autism hub as well, is there a date for the official launch of it, just so we can help share it through our council comms as well? Thank you.
Yeah, so take each of those in turn. From a 111 perspective, yes, it's open to anybody can contact that. Anybody can ring 111 and ask for help and advice. Behind that is so family, friends, anybody that needs to contact. Behind that is a team of professionals that will either provide direct support or signpost the most appropriate service. So we're linking in our complex and specialist crisis teams, but also we've got a helpline that's delivered by Mental Health Matters, and we've got a number of community resources, community teams. So if somebody's already engaged in treatment, we'll signpost them, obviously, and to engage with their work or their professional. But for anybody else, we'll engage them in the most appropriate treatment necessary. It's a triage function at the beginning to offer advice and connection into the right resources. In terms of the Autism Hub, yes, it's live now. There's information on our website, and I'm sure Joe can help us with sharing some information about that to share around.
Thank you. I've got Liz Ball.
Thanks, Chairman. Thanks, Chris, for your presentation. From a Health Watch point of view, we're keen to know about the opening of the PQ, and obviously you've said you're aiming for May, dependent on the Legionella testing. If the Legionella testing wasn't to be as it needs to be to open, have you got any contingency plans regarding that? Before I ask my second question, thank you.
Good question. Yes, I suppose, is the short answer. At the moment, the way that Legionella works is we've got to have 3 consecutive sets of tests that are showing levels of Legionella that are safe for the unit before we can safely open. And the first set are indicating we're in a good position, but I won't speak too soon. Let's just see what happens with the next sets. But if we get to a position where that's not happening and the approach to be taken today, then we can look at different ways of flushing the system to manage it in the way that we've been doing, but in a more enhanced way. The other option is to look at something a bit more dramatic or drastic, which would probably refit of the pipework and system. So those options are obviously available, but we just need to kind of see what comes next. But our board obviously are very keen and watching a close eye on this one. I'm reporting to our board at the beginning of April about progress. If we're not in a position there where we're confident we're reopening, we'll be looking at exploring those alternative options.
Thanks. I think it's just the reassurance that it won't go on much longer than it already has. So thank you for that. My second question, I think you've answered. I know when Steve, your nurse consultant for dementia, came to one of the presentations previously, it was an indication about the memory assessment, and therefore potential patients weren't going to be placed on medication to help with their symptom management for dementia. It's interesting that you're saying now it looks like you're going to be commissioned to develop that pathway. Have you got any kind of time scale on that? Because obviously patients are waiting, aren't they, for those assessments now, and obviously from a Health Watch point of view, we're keen that those patients are waiting as least time as possible.
So for clarity there, we haven't got a funding approved. We have developed a business case in collaboration with our mental health leads in the Integrated Care Board. That's been discussed and considered alongside a whole list of other developments across the county covering all sorts of health options and services. So it's a question of prioritisation at the moment that sits in the hands of our commissioners. Obviously, there's lots of competing priorities. We have put a proposal which we think is really good, will really meet the need, but obviously that we're waiting for that to be considered, and some of that depends on how much funding is available. So we're expecting to know more in the next couple of months about whether that happens or not. At that point, If it's approved, we'll be in a really good position. We'll mobilise that service. If it's not approved, we've got a couple of options. One is we'll be looking again to try and access funding in a following year's funding round, or we will be looking, or we'll be looking at what we can do differently with the resource that we've got. But we're just in the point in time, we'll be just waiting to see what happens with the funding.
So thanks for that, Chris. If there's any support we can give as Healthwatch to support that business case, then, you know, please contact us, our contract manager, directly, and we can try and help in any way we can. Thank you.
Thanks, Liz. I've got Councillor Smith next, please.
Thank you, Chairman. Of the additional 300 whole-time equivalent staff now employed in the organisation, what are their gradings and clinical specialties, which I appreciate, Chris, you won't have to hand, so I'm not expecting an answer now. Secondly, with regards to autism diagnosis, and who and how is the judgment call made on who to prioritise around, and I quote, enhancing someone's quality of life, as this is hugely subjective and very difficult to express probably in a clinical sense, because what somebody might say from a clinical sense isn't going to enhance somebody's life very much. The family of or person involved actually would have a very different viewpoint. So I'd be interested to know how that works in practice. Thank you.
So staffing, no, I haven't got the numbers to hand, but happy to share them. What I would say is there's a mix of roles within there. We know that our registered professionals are particularly difficult to recruit to, but there's a mix of roles within there. Some registered professionals, which is great, we've grown our own, and we've attracted people from other counties, which is also good from a Lincolnshire perspective. But it's a range of professionals. What I would say is that we're working with our workforce teams and our recruitment teams to project what we'll be able to recruit next year. We're confident that number will continue to grow significantly, but we know we've got some hard to recruit to posts in there. Your kind of really specialist senior psychologists and things are some of the kind of harder to recruit to posts, which is going to be more challenging. But but we're still expecting to see that continue. So, but I'm happy to share some more breakdown figures afterwards. In terms of the autism and the prioritisation, it's done really through the information we get at referral, having a conversation at that initial triage, and the professional, a multidisciplinary professional team that just considers the different things that and person's stage in life, what's happening in their life, other diagnosis, and a range of different factors that would indicate whether somebody would benefit more than somebody else from an early diagnosis. Sometimes it's about if somebody's employment might be needing to get that diagnosis to be able to get reasonable adjustments to continue employment and things. So it's those factors we start to consider about who needs the priority over others, considering there's a quite a large volume of people. That said, as you say, the numbers speak for themselves in terms of we're making good progress and we'll continue on that trajectory.
Okay, Councillor Morgan, please.
Thank you. Looking at the Manthorpe unit at Grantham, what measurements are actually being done to assess the impact of the change from hospitalisation of the patients, those who would have needed hospital care in the past, and those who have now been put into the new dementia home care trial? How are we actually measuring the impact on them and perhaps even their life expectancy as a result of the change? The other question is a really quickie, but Virtual Autism Hub, obviously you're looking for third parties to help there. How can they actually contact you and apply if they might be interested? I can think of one or two local groups that might want to do that. And sorry if I can, on the recruitment side, you mentioned that there are new roles being piloted. Could you just explain what they are? Thank you.
No problem. So in terms of the Manthorpe Centre, there's a range of measures we're looking at. One of which is how many people are in hospital, which seems a bit obvious, but certainly particularly for people with dementia, we know that the impact of dementia can change considerably when you take somebody out of a familiar environment and put them into an unfamiliar environment. And we see that as people move into hospital, their level of confusion and understanding can be significantly impacted. So just by being at home is a benefit in itself in that respect. And so fewer people in hospital is generally deemed to be a better outcome. But alongside that, absolutely lots of feedback from patients, from families, members, people who are caring for people, from staff about how this feels, whether it feels like a better service, whether people feel more or less supported. And then alongside that, a number of the clinical indicators, so how many incidents have happened, the use of medication, and indeed where people progress to in terms of how quickly people move into residential care, for example, from own homes. The idea being that we can help people maintain their current and own residence longer, maximise independence for longer. So all those things are being considered, and we're engaging with East Midlands Clinical Senate to do an independent review, because we think we're doing a good job, but we want somebody independent to look at that to make sure that we're doing, what we're doing is the right thing. So, in terms of the Autumn Hub, quick one, if you go through, I think the link is in the paper. If you go through that link, there's an email there. You can contact the Autism Hub, and they'll be able to advise on how to access the support or be able to access being able to be a provider or the grant funding. But if you use email, then that's probably the quickest one. And in terms of new roles, it's a range of different things. So there's some things that are being produced nationally. So physicians associates as a support to the medical profession is one. There's health and wellbeing practitioners that are relatively new, which is a stage between what would be a support worker and a registered nurse, for example. But we're also growing our own and looking at alternative roles. So developing kind of senior clinician roles that weren't there before, so that can work alongside ward managers, for example, to help develop clinical leadership on a ward. Or we've got some other kind of step-up roles from support workers to do enhanced skills and specific practical training that they can add to. So we're just trying to think of different ways we can use the professions differently and supplement them with different roles. And there's a whole host of them, and that's kind of a thing that's happening nationally, but also really quite strongly in the Trust.
Thank you. Councillor Wotton.
Thank you, Chairman. Sadly, both of my questions have been asked by Councillor Wood and Councillor Morgan. But like Councillor Morgan, I just wanted to know if you had any figures, what the knock-on effect from people that would have attended the Manthorpe Centre in Grantham onto the Langworth ward. Thank you. And also, temporary in Grantham, we have a history of temporary becomes permanent, so there is a lot of suspicion in the Grantham area about that unit. But going back to Councillor Wood's excellent question, the 111 service for mental health sounds really incredible, especially for people who are in crisis, etc. But also patient confidentiality would, like Councillor Wood asked, relations, friends, etc., be able to access that service on behalf of somebody. And as I think it's an excellent idea, I hope within the health community, mental health community, it will be well advertised, because I really do think it's an excellent idea. Thank you, and thank you for your report. Thank you, Chair.
Thank you for those. So in terms of the impact on Langworth ward, what I can tell you is that we've got beds available. And I suppose that's the biggest indication, is that we're not overwhelmed, we've not got a queue of people waiting. To be honest, the home treatment team is that effective at keeping people at home with their families or in residential care where they've got a home. It's reduced the need quite considerably for inpatient care, and that's a great thing. That's a positive thing for people and families, maximising people's independence. And so what I would say is there are beds available, constantly there's beds available. So if somebody needs to be admitted, they absolutely can be admitted. So Langworth ward, as a result, is functioning as it intended to do. So I'm confident about that, and hopefully that will come through in the review. What I would say in terms of the permanent and future use of Manthorpe Centre, my hope as Director of Operations is that this model is successful as we think it is, and Manthorpe won't reopen as the ward that it once was, that we will have this new and dementia home treatment team. As we previously reported to the committee, we can't do both. We don't have funding for both. It's got to be one or the other, and what we're seeing, certainly from our perspective of what we're seeing and what we've assessed, is the benefits for patients and families is far greater by having a dementia home treatment team than it is by putting people into a hospital setting. But hopefully the review by the Clinical Senate will confirm or deny that. And that will determine the future. In terms of the 111 service, just picking up on that around the friends and family, our clinicians are trained, our staff are trained to sit behind that in confidentiality. Obviously, it's a sensitive and sensitive area that needs to be carefully balanced. People's confidentiality will be protected, that's absolutely true. But obviously, if a member of a family can ring up, they can get advice and get information in a general way, and we'll signpost them to help and support. But obviously, we'd encourage them to contact. But in most things with mental health, we can't force treatment upon people unless there's specific circumstances. So we would just encourage family members to get their relative to make contact so that we can access and engage them in the right way.
Thank you. I've got Councillor Dilks next, please.
Very kind. Thank you, Mr. Chairman. Good morning, all. I've got two questions, both on mental health. First one following up on the NHS 111 mental health option, which I think everyone welcomes, and follow up, Councillor Wotton's particular comments on it. But I just wondered, is this a reaction to, the police nationally and I think locally also have sort of said, they are not responding or don't intend to respond to, or are less inclined to respond to mental health incidents, if I could put it that way. And I just sort of wondered what impact that is actually having, the police sort of seemingly withdrawing from mental health incidents. And should I go on for the second one? Yeah, thank you. It's on the, later on, the child and adolescent mental health services. I welcome the reductions that you've got, in the 12-week waiting times, clearly. But note, though, there is 14 young people, as it says in the report, currently waiting over 35 weeks for treatment, about 9 months. My sort of just reaction to that is, 9 months is an awful long time when you're it's a longer time in life terms than it is to someone like me or you perhaps. And I just kind of wondered what sort of impact of not getting the treatment early, and I welcome what you say in the monthly calls to them, what sort of impact might that have? And what is the most common age for those people? Is it the very younger children or is it the teenagers? Thank you. You've probably covered this, and apologies if you have, Chairman.
Okay, thank you. So, and sorry, I missed one of the points previously raised around the advertising for the 111 service. We're working with NHS England on that, and it's a soft book on a soft launch. We just want to make sure that we're testing the systems. What we don't want is people to ring up and not the phone not to be answered. So we're doing a bit of a soft launch to start with to make sure that we've got the right resource and the telephony works in the right way so that people aren't left on a call. So we'll be testing that in a soft launch, but once we're confident, we'll then be putting out national press and other things. So it is a nationally driven initiative. It's driven by NHS England, and all areas of the country will be implementing it. So, more advertising to come on that one. Right Care, Right Person is the initiative talking about, which is the police initiative to change the way that the police respond to mental health issues. What we'd say, we're working in partnership with the police on that. It might be worth asking the police to come and talk about that specifically, because it's a police-led initiative, but obviously in partnership with health colleagues. What I would say is that 111, option 2, is part of the solution. That is somewhere that members of the public and others could contact, but it's not the whole solution. We're also looking at different ways that we're configuring our crisis teams and other things to respond, but it's a multi-agency response between fire, ambulance, police, health, to make sure that we've got the right resources in place so that people don't slip through the net. But as I say, I can't speak confidently about that. I think it might be one to direct to the police. And then your final point about children and young people's mental health services. Having people waiting more than 35 weeks isn't acceptable. It's better than it was before, but it's not acceptable. We want ultimately to get to a 4-week wait for children and young people. The target at the minute is to get us down to that kind of 12 weeks, but we will continue to get down to 4. What I would say is we've got the right resource in place after additional investment was made by the ICB. And we've got the right capacity in place to bring that down, and so we're now assessing and treating more people than are coming in for referral, so it's moving in the right direction, and over the course of the next year or so we'll get to where we want to be. In the meantime, we've got people waiting, and in terms of the impact on those people, We are supporting them as best we can to manage their mental health. We've got trained professionals obviously making contact, but with a number of these cases, they need like specialist psychology input for young people. And as mentioned previously, these are some of the harder to recruit to roles that there's a limited amount of specialist resource, but these are people that have been identified as needing that. So we can support in their wider mental health, help them engage with school and other things that they might need to do, but there'll be parts of their mental health need that we're not able to fully address, hence we consider them still to be waiting. And in terms of age groups, it's your teenagers, it's your kind of, 15, 16, 17 years old tends to be the group that predominantly are in that, but I can get more figures on that to be precise.
Thank you. I've got Councillor Wellery next, please.
Thank you, Chairman. I'm interested in NHS 111. I've had quite a lot of interaction with crisis teams in the past. I'm just wondering, it says here the Trust is currently actively recruiting for the new team. Just wondering what mental health qualifications the team will have. And also where it says escalated to local crisis teams. What kind of training will these people have to know when to escalate and which service is appropriate? As we all know, mental health is a very delicate situation for somebody on the end of a phone, and dealing with them in the right way is absolutely crucial. So I'm just wondering what training the operator will have. And when it comes to the young people that are waiting, is there still a facility to place out of county, such as at the Priory and other units, or is that now not a policy adopted in Lincolnshire? Thank you.
I'm already on. NHS 111, we've thought long and hard about this through all our different meetings and governance structures in the organisation to make sure we've got a balance between getting the right level of expertise and be able to recruit enough staff to fill the post. And we're confident in the model of staffing that we've come up with, which in essence is a combination of registered specialist professionals and non-registered specialist professionals. So at any time on duty, there'll be a combination of both. So that means that if it's a non-registered professional that answers the phone, which predominantly what happens to do screening and triage, they'll be given training on the job to be able to do as a part of their induction and a full training programme through what's available in the organisation, but they'll be supported on duty by a specialist registered professional. So if there's any issues, they can dip into calls, they can take over calls and offer advice and support. So we're strengthening that front end to services really. What we're saying that sits behind that then is our specialist crisis teams, other support services, our crisis cafes that you've heard about before, is that depending on what the need is, a number of people bringing up will probably just need maybe some support, a listening ear. Some people will need something more structured, people will need something more specialist. So that team is designed to do that. What I would say is we'll keep that under constant review. This is new to us. It's a new thing that's coming through. Call volumes. We don't know if by advertising it nationally we're going to see an increase in call volumes. We're not 100% sure yet because it's untested, certainly here in Lincolnshire. So we'll be looking at that and monitoring that, and certainly our board again are keeping a close eye on that one. Children and young people, just say that what we're talking about in terms of waiting times doesn't affect the inpatient access, so that remains the case. People can access inpatient services in the same way they've done traditionally. This is about people who need community support. If their needs were deemed to be complex or high risk, we'd be seeing them much more quickly, and our crisis teams would be involved for children and young people, and there would be access to inpatient services. These tend to be the people who've been seen who we think their needs aren't as immediate, but obviously ongoing.
Okay, thank you. I've got Councillor Kendrick next, please.
Thanks, Chairman. You'd be surprised to hear that I'm not going to ask a string of questions. The reason being, a couple of weeks ago, I submitted a number of questions as a governor to the Trust as I wanted to get some more information about the Trust. But one thing has prompted me this morning as regards to discussion on recruitment and also the areas such as CAMS, is the question I put to the Trust 2 weeks ago was about the extent of locum medical costs and the size of that in the Trust. But I didn't include, and I should have done perhaps, the extent of locum psychology staff particularly in relation to CAMS, as I know historically access for young people to psychology services has been difficult over the years. And just if you could just take that back, Chris, that'd be marvellous. Thanks very much. Thank you.
Thank you. I've got Councillor McGee next, please.
Hi, thank you, Chair. I hate to be the critical voice. I'm so sorry. I can say that children are not being contacted on a monthly basis while waiting for CAMS. I had one of my own children, it was 4 months before he had any contact, and my current daughter is 3 months on the waiting list and has just had her first appointment come through for next month. So that's not happening. Can you please go back and check those figures? And a little quick question with regards to talking therapy waiting times. It says 6 weeks to commence treatment. Is that 6 weeks to commence treatment or 6 weeks to be assessed?
So I can only apologise for your experience around the lack of contact. That's a service we put in place. I will go back and make sure and check out exactly what's happening there. In terms of the talking therapies, it's not a complicated picture, but it's one of these things where we're monitored on access, so that first appointment, and what we can do that very easily. We can just see people very quickly. But obviously, then you, like any process, we then create a backlog somewhere or a bottleneck somewhere in the system. And so what we've said here is what you're seeing in terms of talking therapies is that we've got, at that initial stage, talking therapies is a stepped model. So you come into services and we will offer initially self-help if that's indicated, and then you step up to more complex and structured therapies and treatments. What we're seeing with talking therapies at that lower end, we can see people really quickly, and if they've got needs low, we can turn that around and people can be get the help they need and off they go. If people then have got more complex need in this kind of step 2 element, you're seeing that we're creating a waiting list. So as we described there, there is a wait there. What we're trying to do is recruit additional staff. So again, we're always asking with commissioners to be able to expand that capacity, but we've also agreed to outsource some of that. So we're using online therapies to supplement the physical face-to-face staff treatment. So and they give that choice to people. So that's the idea, is you've got two options, and a number of patients quite like the online therapies, and so that's trying to think creatively about creating capacity when we know we've got a service that's in high demand.
Yeah, I'd like to come back on that because the wording of that is 75% of patients commence treatment within 6 weeks, which would suggest that people are accessing therapy within 6 weeks. And they are absolutely not. So they are being assessed within 6 weeks quite regularly. But treatment times when you've been assessed as needing therapy is more like a year in many places. So I work in the building that talking therapies are in. I'm not currently LPFT staff, although I'm due to be soon. And I liaise with patients regularly, and they are being told 9 months to 18 months until they access a therapist. So I'd like to see these figures reflect the assessment, then how many people are accessing actual therapy that they've been deemed as needing, and how long those wait times are, because that gives this committee a much better understanding of how long it is until people are actually accessing treatment. Thank you.
Yeah, if I may, I think maybe it's just not drawn out as well in the report as it might be, and happy to bring something back. I think what we're trying to say is in terms of a number of people are accessing that first level treatment and it's enough to meet their needs. So, and there's an argument about trying to get high volumes of people through so they can meet their needs and go onwards. What we've tried to say there for some specific treatments as people step on, they are waiting a considerable length of time, but it's this balance between seeing enough people at that front door, because we can treat lots of people there, but recognising then that creates a bottleneck up in the chain. But what I will do is I'm quite happy to bring something a bit more detailed back on talking therapies if that would be useful at some point.
Yeah, thank you. I think that'll be very useful. Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. I was living in the east of Lincolnshire. We've got a lot of elderly people, so consequently we have lots of cases of dementia. I think keeping people in their own homes is a lovely idea, but what exactly is dementia home care? Because that sounds to me like somebody comes in and helps you in the home. I don't know anybody that is getting that sort of help and support. And often the people that are caring for people with dementia are old partners. They really do struggle. And I've got a very dear friend who's actually got to the point now where he can't decide whether he should put his wife in the home or not. Is struggling really to keep her at home, but she's getting worse and worse. So what exactly is dementia home care, please?
Yeah, so again, I suppose being specific about the title, it's a dementia home treatment team, and it's the emphasis on the treatment element. It's a hospital home. So previously, Banthorpe Ward was 18 beds for people who needed assessment for their dementia, usually getting to a point of breakdown at home. Things got into crisis point, and somebody would be admitted to us so that we can get an understanding of what's going off, maybe prescribe treatments of different medication or other things, and then work out where best next to go. Some people go home, or people would go on to a care home. What this home treatment team is doing something similar. So this is not a widespread service available to the whole county. It's kind of hospital home that's dedicated to those people that that we're worried about, that are in the community, usually open to our community teams, whose needs are deteriorating, and we're concerned. So the home treatment team will go in. What they're doing is basically it's a higher staff to patient ratio, so they can go in, provide more intensive support, help people to maintain, work out how to do regimes and different patterns of different techniques to keep somebody at home, because that's often what the family want. But when that becomes unmanageable or it's not what's wanted, we'll help to access a care home support or other, rather than somebody have to come into a clinical hospital environment in order to step out. We can resolve much of those issues and intervene much earlier in the community. But it's a discrete team that is, in essence, has a capped caseload to care for a small number of complex patients, to keep them out of hospital and to access appropriate care.
But how do you access that service? Because that is a problem for most people, knowing where to go for that sort of help. And because you can't get a GP appointment in the east of Lincolnshire and all the rest of it, so people are really up against it, and especially older people.
So I can't speak for obviously primary care, but I can, in terms of the services that we're providing. We have a community mental health service. We have a dementia workers in the community, so they'll often get referred to by other professionals. Primary care is the usual source, so people have been to the GP, people are concerned about memory, or people have come through our memory assessment service from other health professionals. Our community mental health teams will get involved, try to engage them, but that's the capacity of those teams. Is we've seen them once a week or twice a week at best. But if their needs deteriorate, we can send the home treatment team in, but the referrals will come from our community mental health team. They're like a step between inpatient care and our community mental health teams, and the referrals come in there. They'll just keep people, hopefully turn things around so they don't have to go into hospital. But I say it's professionally referred into. It's not open access to the community.
Okay, thank you. Councillor Geeney next, please.
Thank you, Chairman. At the Child and Adolescent Mental Health Services, the 14 young people, say, waiting over 35 weeks, I just wonder what happens if these young people and other ones that are waiting less time become 18 during their waiting period. Do they then go to the bottom of the ladder, if you like, in adult mental health, or are they continue to be cared for because they're already in the young persons one? Thank you.
Yes, the answer is they'll continue. They won't go to the bottom of the pile. They'll continue to be in child services. We do have an arrangement where we can keep people up to the age of 25 in our young people's services. So if they were referred, we wouldn't send them to adult services to start again. We would make sure their needs are met. And then we're just working on a new transitions protocol, which is the kind of changing as children grow older and move into adulthood. And just saying that's a needs-led process and not an age-led process. Age is the indicator, but then we'll do a needs-led process about when people move on, sometimes based on developmental age rather than physical age. So absolutely. What I would say, just to add on the waiting list things, I suppose it's coming in today is that we've talked to committee before about the challenges we're having with waiting times and the volume of work that's coming into and demand that's coming for services. It's not great. It's not where it needs to be on a number of different fronts, and I hope I haven't portrayed in the paper or when I was speaking that we're happy with where things are. What I'm trying to explain is things are better than they were, but they're nowhere near where they need to be for a number of different service users. So.
Yeah, I'll allow you to come back, Councillor McGee.
I actually really appreciate that honesty, that it's moving in the right direction. Just one quick question with regards to the veils. I can see that you're talking to staff, and I have staff that are, I know staff that are currently working in that setting, and I know they're being contacted for feedback. Are you also contacting the community staff that refer patients in and deal with patients when they come into CMHT and have that follow-up work? Because obviously, when someone comes back into the community, they're more likely to stabilise, have a period of reflection, and be able to talk about their experiences on ward more openly, perhaps, than they would with staff on ward. So are you engaging with those teams as well?
Yes. So what started off quite a small focused piece of work is broadening out, as these things do, but we absolutely want to talk to staff across the different teams, patients that have been in and out of services, family that's been using those, got relatives that use those services. But what I'm looking to do, whilst we want to do a piece of work specifically on the Vales, what I referred to earlier is what we're saying is actually this is probably a broader problem that comes across all our female inpatient pathway, and I'm going to be heading up a kind of task and finish group around that to be able to just try to look at a different way of configuring services. How can we use our resources better? What can we do differently? So really committed to trying to improve things, because it's not, again, it's really hard for patients, it's hard for staff in those environments, and if there's anything we could do to make that better, then we will. But so yes, in answer to your question, short, yes, staff will be engaged and are being engaged. Hopefully I can see Joe nodding at the side of me, so that's the case. But we realise we need to broaden that out to be a much wider piece of work as well.
If we could grab each other at some point or an email afterwards, I've got some feedback that you might find useful for that process on a personal level, so that'd be great if we could have a chat. Perfect.
Councillor Morgan, you keep putting your pen up and down, so I'm not sure if you're expressing you want to speak. Yeah, okay, Councillor Morgan, I shall allow you in.
I appreciate I've had a question already. Yeah, I'd just like to follow up a bit more deeply regarding the dementia care at home. Because obviously there are mental health issues with dementia, but there's also medical and acute medical needs relating to dementia. So how are we managing those if we've taken people out of a hospital environment where they'd have perhaps a consultancy team covering multiple areas, medical areas, to removing them into a home environment? I have to confess, I'm not convinced they're going to get the same level of care in that area by moving them away from the hospital. And I did speak to some coroners who, I mean, they have identified dementia as being the highest cause of fatality now in Lincolnshire, and I'm just wondering, that's why I asked earlier about the life expectancy as well, the difference where the patients were kept up in the hospital and those medical needs addressed versus what's happening now, they're moving into a home environment. Yeah, no, great question. I think, again, maybe I've not explained it well enough in the paper, but in essence, it's a hospital-at-home model. So the same range of professionals that were available to somebody when they were in our dementia inpatient ward are available to somebody that are in the community now. So consultants, registered mental health nurses, and other things. So the ward was a mental health ward, well, dementia ward. It wasn't a medical ward as such. So it was a dementia-specific ward, and we've just replicated that model, but in the community, so we can maintain people's support at home. What I would say as well, it's helpful to think of it on a continuum of care. So stemming right from people being supported in community groups, through our community mental health teams, the dementia home treatment team then comes next as a high level of support, and then inpatient services. And a patient might move up and down those different things. So the people we support in dementia home treatment may well go into inpatient care if that's what's needed, but hopefully for a shorter period, and we will help them with our dementia home treatment service. So it's the same patients, and we're just giving more options in that pathway so that we can meet their needs at different levels. Whereas before, if somebody's needs were greater than being seen once a week, they had to go into inpatient care. We had nothing in between, and that the dementia home treatment team is filling that gap.
Yeah, you want to come back briefly?
From my own experience of my mother, who was in a general medical ward, what support then do we have within Grantham and our other hospitals when it comes to somebody who has got dementia, maybe severe dementia, has medical needs? How are we then caring for them? Because they can be incredibly disruptive on an ordinary ward, obviously no fault of their own.
Absolutely. So in that essence, we've got what we call our mental health liaison teams. They're a combination of nurses and medical psychiatrists. We specialise in older people psychiatrists, and they're in that team, and they are based in the hospital, and they provide support and advice to the medical hospitals. So Lincoln County, at Boston, at Grantham, we've got liaison teams that will provide specialist advice and support on how to manage somebody with dementia or mental health problems in those settings. So it's a small team. They go in and assess, they give advice, they help with the care planning. They don't necessarily do the hands-on support. That's responsibility of the hospital itself.
Thank you. I've got no further speakers, so I'm going to close down the debate after I've got a few questions myself. So my first question is, on page 21, regarding the PQ closure, could you expand on where the out-of-area placements were and how long they were on average? And when a patient is treated out of county, has this had a negative impact on the treatment, with them being away from friends and family and potentially reducing them from being able to visit? That's my first.
Now, I've forgotten the number specifically. 14?
It's 15.
15.
15 during the closure.
Yeah, 15 during the closure, so I thought I had that test lined up and I failed at the last minute. But so 15 people have been placed out of area. At any one time, that tends to be between 3 and 4. What we've done is worked hard with our other services to keep people in our acute wards, and that puts pressure on our acute wards, but we want to minimise the impact of people going away from home. That is sometimes far away from home, and that's the problem with out-of-area placements, because there's pressure nationally on beds available. It's not a choice. You go where the bed's available sometimes, and so we've got people in Essex, Nottingham. Sometimes we go further afield than that, and so what we would say is that in those cases is our bed management team are in constant contact. They are regularly dialing into or attending ward rounds and other things to make sure people are brought back as soon as possible. How quickly they're brought back depends on the person. That can vary from, it could be a short admission for a couple of weeks, or it could be, several months, and it just depends on the individual, but it's very variable. I'm confident as the unit reopens, for those male patients, we'll have enough capacity in Lincolnshire to support both acute and PQ needs, and we'll be able to keep everybody local unless it's a particular choice.
Thank you. And I think the other part of that question was, does it have a negative impact on that patient being taken out of area as opposed to being treated close to home?
Yeah, that's the evidence and the feedback. Some people want to go. I mean, there's a choice that people might want to go, or there might be particular issues around safeguarding, for example, locally, that means somebody would be better placed further away out of county. But yeah, it's taking people out of their homes, taking people out of their own communities where the friends and family can easily access. And we know how important friends and family are and your communities for people's recovery and mental health. So it is a negative impact. What I would say is the quality of providers that we use, we choose carefully, and we know they're good providers that provide care that's equivalent to our own. But you can't get away from people being away and detached from their friends and family, which is not a good thing. So the sooner we can get the unit open and get people back, the better.
Okay, thank you. My next question is, how many people do you expect the expanded adult eating disorder services to treat in the coming year?
I'm going to have to get back to you on that one.
Thank you. And then page 25, section 4, can you expand on what areas are most at risk with recruitment and retention, and if we are likely to see further temporary closures taking place in the near future?
So, second part first, no. At the moment, I'm confident that we've got the right levels of staff in to be able to maintain the services we've got. I wouldn't be proposing to reopen the PQ if I wasn't confident in that. In terms of where the pressure felt, it's varied. Because we've got expansion and growth of service, or have done over the last few years, staff have got a bit of a lot of options where they go, so people are moving around more frequent than they used to. So we see a team being quite well staffed, and then suddenly people will move on. Oh, this looks interesting, something new, or a different team, and then people follow each other around. Obviously, got colleagues they work with. So we've seen it moving around in different places. We had a particular pressure in our children's services over in Boston. That's still a really hard place to recruit to in the east of the county, generally. However, we've got some really good positive recruitment. We had a really good recruitment activity over at Boston Football Club the other week, and that generated lots of interest. So we're seeing it improving across the board. Medical consultant recruitment is a particular persistent issue. and say some of our more specialist roles around like specialist psychology, there just aren't as many people out there, and we want to grow those services. And so again, it's a more difficult to recruit to role, but I think at the moment medical staffing is probably one of our biggest challenges, and we're quite heavily reliant, as mentioned earlier, on locum doctors. That doesn't mean they're not good and they're not doing a great job, it's just they're not substantive regular staff, and obviously we prefer that if we could.
Okay, and my final question, again under recruitment and retention, there is reference to the Trust's accreditation as part of the National Timewise scheme. Can you expand on that?
Yeah, so it's a programme that's available to all public sector organisations. It's an accredited scheme where you've just got to demonstrate that you are offering different ways of flexible working. So obviously part of our recruitment and retention strategy is try to find different ways to make working at LPFT a great place to be, and part of that is trying to offer flexible arrangements whilst meeting service needs. So that's what it refers to.
Thank you. Okay, in which case I'm now going to make a proposal that we welcome the planned expansion of the Trust's Adult Eating Disorder Support Service, the launch of the Virtual Autism Hub and the improvements to recruitment and retention across the Trust, and to consider any service changes arising from the Dementia Home Treatments Team pilot and the review of the Vales at Discovery House at an appropriate future date. Do I have a seconder to my proposal? Councillor Woodson, thank you. All those in favour, please show. Thank you, that's supported unanimously. And just thank you to Chris for attending today. I think it was a very helpful report, and we look forward to some of the feedback that's been picked up today coming forward. Thank you. Okay, in which case we'll now move on to agenda item 6, the Lincolnshire Voluntary Engagement Team. This item was circulated as part of the agenda pack and is on pages 29 to 37. This item enables the committee to have an overview of the activities of the voluntary and third sectors in supporting health services in Lincolnshire, and I'd like to welcome our presenters on Teams, Chris Wheway, Chair of the Lincolnshire Voluntary Engagement Team, also Chief Executive Officer of St Barnabas Hospice, and Paul Gufferson, Managing Director for Lincolnshire Voluntary Engagement Team. If I can hand over to you, and if you can just walk us through the presentation for 5-10 minutes and take questions at the end, if that's okay. Thank you.
Thank you for your invite, Chair. As I said, my name's Chris Wheway, Chair of LVET. If I could invite my colleague Paul, who actually has the credit for the work, to sort of do the step through the paper, I'll hand over if that's okay.
It's fine.
Thank you.
Thanks, Chris. So good morning, everyone. As everyone knows, I'm Paul Gufferson. And so the paper that we've put before you really is to set out really to summarise the work that LVET does. So that's the Lincolnshire Voluntary Engagement Team, and who we are really, and the role that we play within the health and social care delivery for Lincolnshire. For those that don't know much about LVET, we are a collective of voluntary sector organisations, community, faith and social enterprises amongst those as well. And our members directly deliver health and social care services, and but some of that might be through leisure and fitness activities or other kinds of community-based activities. Currently, we have just short of 150 member organisations, so it's actually gone up since this paper was put in. The majority of those are small to medium-sized organisations with incomes of around about 100,000 or less than £100,000 a year. But collectively, our members have a sizable workforce, especially if you take into account not only the paid workforce, but also the unpaid volunteers that support the work that's delivered. So just amongst our members alone, that's about 8,500 people. In terms of the investment that comes from ICB and Lincolnshire County Council, we've been very fortunate and been grateful for the support that comes from those parts of the system to support the work that we do, and the recognition that comes with that of being a valuable contributor to delivering positive health outcomes for the people of Lincolnshire, and that investment helps us to support our members to access additional funding and levering in additional funding, and it also enables LVET to run and manage projects and contributions to innovation and developments that help the system more generally make positive changes to, as I say, the health outcomes for the people of Lincolnshire. During LVET's lifetime, we've worked quite positively with the system to make some significant changes happen, and we delivered programs of change where a county-wide organisation was perhaps needed, or where just an independent organisation was perhaps needed to help manage those programs to make them happen. Obviously, a big success for LVET was the response to COVID-19 and the ability to help mobilise staff and volunteers to support the county-wide vaccination programme. And part of that was also the digital system that sat beneath that and helped coordinate things. So helping that delivery of over 500,000 vaccinations. The paper also sets out a few other programs that we've been key to delivering and enabling that rapid response of support to people in need in terms of health and well-being. Our membership, and through our paid staff, a very small team, and our directors, we sit on a lot of working groups and steering groups and strategic boards, and our key drivers for that are to make sure that the voice of the sector is heard, and that we are able to contribute effectively to improving outcomes for people. It's also true that we kind of try hard to push our members to innovate and to support innovation and development that's going on in other parts of the health and care sector. So we are very focused, especially through Chris's involvement as the System Responsible Officer for Personalisation, in driving the personalisation agenda, partly because that's where a lot of our strengths as a sector lie in terms of the delivery of that agenda. We've been central to supporting the development of social prescribing and the use of social RX as a data management system to help manage the caseload of social prescribing in the county. Again, it's a project where it was needed, a county-wide organisation was needed to support that. We are working very strongly at the minute in terms of trying to drive the Lincolnshire Volunteer Programme, working with VCS, LCVS to make significant changes and improvements in the way that volunteer management happens in the county. And that is not just within voluntary and community sector organisations, but also within other parts of the system. So NHS volunteers, for example, using the Lincolnshire Volunteer Programme digital system to manage their volunteer recruitment, and the future developments around that are very much around actually volunteer retention and reward, and linking that into the drive for volunteer to career within NHS roles. We've also this year been quite active working to develop social enterprise, amongst our members, and working with, and we've brought funding in from Barrow Cadbury Trust, and working with some local partners, including the Greater Lincolnshire Social Economy Academy, but also with the School for Social Entrepreneurs nationally, to look at how we might develop some social enterprise leaders within the voluntary and community sector. We're also really pleased that we've been able to work with the Integrated Care Board to launch the Health Inequalities VCSE Grant Fund, making money available to voluntary and community sector organisations of various sizes. I had the great pleasure last night of going to one where they're building a mini Land Rover, which will then be raffled off. But the work there with the young people that are involved in that project is one side of the success story. That the other side is actually it's built a relationship and a partnership with Duckworth. So it's building those relationships between voluntary community sector organisations and private sector organisations, which can only strengthen things and help improve the resilience of the sector. We try really hard, as I said, to be innovative and to bring new opportunities and ideas into Lincolnshire. One of those was working with an organisation based in Somerset, but who had National Lottery funding to develop a digital mapping tool that maps communities and the connections within communities, and helps you understand the relationships between organisations and relationships between people. And this has been, I think, picked up by the Channel 3 team who are carrying out the system-wide digital review, which is just one example, I think, of where we engage with those bigger system-wide reviews and contribute to those as much as we can. I think the other role that LVET provides and supports within the health and social care environment is that we can help to share the struggles and the challenges that our member organisations face, and I think it's no surprise that actually currently increased delivery costs within fixed value contracts, short-term funding arrangements, staff and volunteer burnout in the same way as within statutory sector organisations is a challenge, and as is staff and volunteer recruitment and especially trustee recruitment as well. We're really pleased, as I said, that LVET's role has been supported up to this point by Integrated Care Board and Lincolnshire County Council, and I'm really excited that the success of what we do has been recognised and that we're entering into a new 5-year agreement, and that will help us to, I think, strengthen that commitment and that collaboration, and show is a good example of the system maturity. So that's really, really welcome, and we're really pleased that that's happened. So our future plans very much revolve around the role of community and voluntary sector organisations and faith and social enterprise organisations in enabling communities to take responsibility for their own health and to stay healthy longer, to deliver services where those services and activities can add value to the statutory sector services, to take seriously our role in improving workplace health, in that, as I said, we employ, in terms of paid and unpaid staff, over 8,500 people in our membership alone. So there's a significant role we can play around that. And also there are things that I'm sure we can work together to help with the pains that the system feels, especially around things like the management of long-term health conditions. We have just revised our strategic objectives, and these will be launched at our conference, which is coming up in April, where we'll bring roughly about 180 people from across Lincolnshire together to talk about the difference that we make and to talk about impact and how we tell our story better, because that's important and that's something we need to improve, and we know we need to improve. Individually and collectively, we do make a big difference. So our new strategic objectives, we've split them down to 4, and they are very much around our ability to provide strategic representation for health and care organisations.
Excellent, thank you. I've got people ready to speak now, so Councillor Kendrick first, thank you.
Thanks very much, and hi, Chris. We go back a while. I wish this had been in place when I was in the managing volunteers in the NHS. It came into existence the year I retired from managing volunteers in the NHS. So I think it's a great idea. The only thing that I noticed, and Paul mentioned, he used the term employ people in unpaid roles, and I'm sure that's just a sort of a slip there, because obviously no contractual arrangement can exist between a volunteer and an organisation. You'll be familiar with the case some years ago of some volunteers in a CAB who tried to claim employment rights, and that was dismissed. But I'm sure that was just a sort of slip there. I was just wondering, how many staff does LVET employ? I just wondered about that one, but I think this is a marvellous thing to have, and liaison between organisations. I was going to ask about managers and volunteers in the NHS, but you've mentioned that, actually. Paul mentioned that there's a liaison there, because it struck me looking at the chart that it was very high level engagement at board level, and I was just wondering about engagement at the sort of the sharp end, but I think that's been mentioned now, so that question's been answered. So it's really just how many staff are really involved by LVET, but more power to your elbow. Thanks, Chairman.
Thank you. That's lovely feedback. Thank you. Paul, do you want to answer the question about the members of staff?
Yeah, thank you. Yeah, so in terms of members of staff, we have 4 members of staff, one of whom is seconded from VCS, and whose role is very much solely focused on the personalisation agenda and the relationship with PCNs. We have a membership officer, a programmes officer, and myself, basically.
Thank you, Paul.
Okay, thank you. Do I have any other speakers? Councillor Morgan, please.
Yeah, thank you. With so many organisations all delivering in the same area, how do we ensure the most effective use of the resources and that there isn't duplication, overlapping, etc.? That's the first question. And the second one is just being mindful of some local requests for support. Do we consider the provision of music and singing as being something that is conducive to well-being and health? Thank you.
Well, I will thank you. So some very good questions there. The first one about music and singing, I would say yes, absolutely. And my experience, particularly in dementia care, is that music and singing is something that can bring about radical change, more than, frankly, medication can. So the answer is yes to that one. I think the complexity of our sector is that it is vast. There are huge numbers. It ranges from 2 or 3 people meeting together in a church hall to rather large, big organisations. And I think what we with the support of Paul and the team aim to do is to make effective use of all of our resources and to help them have strategic impact. Because I think the key with our sector is because it's so big and so wide, that there is a danger that it's incredibly difficult for the statutory sector to engage with us and work with us. So, our role really is to make sure resources are used effectively and that our sector is able to respond. But for me, as the chair, the vision for this is to ensure that the smaller organisations and the small groups of people get access to the funds. And it's not just the big people, big organisations that are loudest in the room. And I think that's the, I think will be the true measure of our success in years to come, is that how have we engaged the wider sector working within the health and care system. So I hope that gives some level of answer to the question asked.
Yes, thank you very much.
Thank you. Councillor Wood.
Thank you. I've just got a bit of a similar question. So the map on page 37 is really helpful, detailing the names of different working and delivery groups. I just wondered if someone wants to make contact with one of the reps from them organisations, what's the best way to do that? Thank you.
Paul, did you want to?
Yeah, I think the best way to do that is to contact me. And one of the things we're trying to do at the minute actually is work out how we make the information around these different groups and working groups available to our members. But initially, the route to feeding into those groups or getting feedback from those groups is via, via myself or other staff members or directors. So the easiest way to do that is through communicating with me, and my email is on there, but I'm sure Simon could share that as well.
Okay, thank you. I haven't anyone further that's stated they wanted to speak, so I've got a number of questions myself. On page 31, there is a reference to LVET supporting service redesign through 60 working groups, steering groups, or boards. Can you expand on the comment in the report about the timelier involvement and effectiveness of these groups, please?
Yeah, so the comment there really is around the fact that we are a collective. We represent, to some extent, 140 organisations, 150 organisations, somewhere around about that at the moment, all of different sizes, all of whom have different capacity and resource issues, and to enable our members to voice their concerns or to make contributions of positive nature to any of those groups, they need time to be able to do that. So sometimes the time scale of being of LVET being contacted perhaps a week or 2 weeks before a board meet or working group meets, that doesn't give us time to effectively talk with our members so that they can feed back into those working groups. So it's about that, trying to find a mechanism for more effective collaboration and enabling people to have a voice.
Okay, thank you. My next question is on page 32, there is a reference to the challenges which include staff and volunteer burnout and recruitment and retention. Do these challenges affect any particular type of voluntary, community, faith and social enterprise organisation more than the others? And have these challenges become worse since the pandemic?
Sorry,
I'll let Chris go. Let Chris go because you go on.
I would suggest I've been put into, unless Paul challenges me, which is quite happy to. I don't think it necessarily affects one particular group or others. I think it's a general theme, but of course I think what's been happening sort of during the pandemic and post-pandemic with the financial challenges is that I think all organisations, all people and all groups are struggling. So I think it is. I think we are seeing the impact of what everyone is facing, and I think the ability for people to volunteer when things are very difficult are there. I know I find that with my own my own organisation that I'm chief exec of. So I think the challenge is overall, and I wouldn't necessarily pinpoint it in one specific area, Chair. But Paul, unless if you've got anything to add to that, please do.
No, I think the only addition I would perhaps make is that at senior leadership level within voluntary sector organisations, there is an increased feeling of pressure. I think that's the reality of the world that we're living in terms of increased delivery costs and the like, and so they feel that pressure very keenly. I think.
Okay, thank you. My next question is, are you able to give an idea of the total amount of funding from the NHS in Lincolnshire given to voluntary, community, faith and social enterprise sectors through contractual arrangements, for example, with the ICB or NHS trusts, please?
Well, go for Paul.
sorry, Chris. I mean, I'll throw. Funnily enough, we were just having this conversation in the meeting that I was in before this. We can't. We have asked, and we do believe that it's being considered how that can be shared with us, because actually we don't know the total that from but actually the ICB and other commissioners of services should be able to tell us what that is as well. We are currently looking at how we get better data from our members and from non-members around where income comes from into the sector.
I'd agree with that. Just to add on that, I think actually it's a very good and timely question, because I think really over the coming years we should have that data, because we should want to benchmark the data over the years about. I would hope that it's an increasing investment in the sector, but I do know at the moment that it is being squeezed. So with inflation and other cost pressures, the minimum living wage has had a tremendous impact on our sector. So I think it's a good question that we we ought to have the information, but I think it's something that should be monitored, because I think if we're not careful, that investment is going to reduce because of things like inflation and other things that are outside of our control.
Okay, thank you. Councillor McGee, I'll bring you in.
Yeah, I'd just like to comment on that point actually, because we just had LPFT in here talking about the virtual autism hub and saying that eventually they would like that to be taken over potentially by some sort of community group. And this is happening all of the time, where the community sector is picking up where the system is creaking at the seams, if you like. And if we don't monitor that funding and how it's being spent and the outcomes that come from that, there is a danger that it will just be reduced, and therefore those community groups that are doing that fantastic work on the ground will lose the funding. And we're seeing the impact of loss of funding across the board with organisations like BRIC recently in the area. It's just devastating to see. So they do a fantastic job. LVET is a fantastic voice for that sector. But I'd like to second what you say, really, in that we need to have those figures to make sure that that funding continues.
Thank you. If I'm able to just quickly respond to that, I think that's a very helpful comment, and I think the danger with our sector is that we're not taken seriously as a sector, and that we do need investment, we do need resources. And my suggestion would be that actually the investment in our sector should grow and grow on the basis of ensuring, particularly with the NHS, that it is able to focus on what it should be doing. And I think our sector has huge potential opportunities, but it's not free, and it does need investment and it does need support is the answer. So I would add everything to what you've just said. So thank you.
Thank you, Councillor Dilks.
Yeah, thanks for that. I've listened, been fascinated with the discussion. Thank you. It's just sort of really a personal comment on, the voluntary sector, everybody knows is absolutely vital to cohesion of communities, and they do so much. But it's the sort of area I just sort of wanted to sort of look at briefly, and it doesn't seem to have been touched on really, is the difference in areas, the geographical difference. In my area, I'm very lucky to live in quite a well-to-do sort of area, and there's I wouldn't say there's no shortage of volunteers, but if things need doing, there's always a retired teacher. People have taken early retirement in my community, but if you go to, dare I say, Bootham or perhaps the Ermine or St Giles, some other areas that are less deprived, those people, if they've got jobs, they're going to stay in them much longer, and they're not going to have the wherewithal to become volunteers. And so it's almost a sort of an imbalance. And then the second sort of point was where you mentioned burnout. I'm chairman of Age Concern in my community, and we do, not me, but people do an awful lot of voluntary work. But I am beginning to find in getting people to volunteer now is becoming increasingly difficult, even in a well-to-do area like mine, because of the red tape that comes with it, the requirement for safeguarding and, yes, other courses that you have to do, quite naturally, of course. But I've got people who are now in their 80s who volunteer, still volunteer really, really good, who sort of hark back and say, oh, we didn't have to do that in my day. We've moved on. Of course, those things are important, but it is about a balance in the requirements of volunteers. I, as chairman, I want, we've all got to have all these qualifications to make sure we protect the reputation of us, Age Concern, and that we're protecting our clients, those that we sort of help. But it is a real challenge. I just kind of wanted to make that comment. Thank you.
Yeah, thank you for that's really helpful feedback. I mean, I do think, again, being an organisation as in St Barnabas that has a large number of volunteers, there's a middle ground. There's a pragmatic middle ground in how you work with supporting volunteers around the mandatory training and support, and you need to do it in such a way that isn't burdensome and actually is supportive. Because, as you mentioned, mandatory training it's an organisational support, but it's also supporting and protecting the individuals involved. I also think the nature of volunteering in this modern age is changing and is different, and you have different generations have different understandings of volunteering. I mean, obviously, our sector is a range of made up of a range of paid and volunteer workers and support, all of which are incredibly important. And I think the volunteering side of things is well, health and care would not survive without volunteers. It's the people who care at home, all sorts of different things, as well as the stuff that we understand more and more. But volunteers do need support. That is the bottom line. You can't not. And Rob and I have worked together for many years in the past. It's an area that hasn't been supported. I think people have had the risk in the past of seeing volunteers as a free support. It's not. It's a vital support, but it does need investment and cover. And as for where things are across the county, yes, there is differences, and there are geographical differences. And I think part of our role is, if we can, is to support communities coming together and doing things differently. But Lincolnshire has a very, very vibrant VCSEF, and I keep forgetting to add the F into it these days, has a very vibrant sector, but it is different wherever you are in the county. There is no two ways about that. But I do think volunteering as a whole is changing. I think the pandemic changed that. But I also see it with the younger generations. They have a very different concept of volunteering than previous generations.
Thank you. Councillor Morgan.
Yes, thank you. Just kind of continuing on that theme. One of the things that strikes me, in Grantham, we've got churches together. So there's a very strong dependency on the church to deliver the core infrastructure, and from that there was a significant then level of support into the community. It does seem very much the same volunteers involved in a number of organisations, and they are getting older as well, dare I say. So it is really worrying. We're not really seeing necessarily younger people coming in. And what concerns me is actually the churches themselves are struggling for funding and keeping going, and we've become so dependent on them to deliver key services. I'd be quite interested in your views around that. And is there anything, turning it round, is there anything that we can do as councillors members to support the voluntary sector more What can we do? Because I think you're quite right that there is this perception that somehow it's free. We've had really good organisations close. One of the biggies actually has been insurance costs for some of the provision, which is, that's just escalated ridiculously and has led to, as I said, some events and activities just completely folding, which is so sad because they just can't get that seed money anymore that used to be available. And the other thing is access to buildings. It really worries me that basic infrastructure that the voluntary sector needs just to keep going, vehicle costs, that it's really, really difficult now for those needs to be met.
Thank you. If I say something, Paul, please, if I go first and then Paul can come. And my first comment is related to you guys and your support for us, for our sector, the VCSE FC sector. Is the first thing is you've invited us here, so that to me is a tremendous support to give us our ability to speak up. I think really the support that we need is to be recognised as a vibrant, dynamic sector who can make change and can actually help and support. I think it's about your support in recognising that in a time of financial crisis and things that are happening in the country and in the world, our sector does feel it very, very acutely. And you've talked about the churches, you've talked about buildings. I was talking to my welfare rights team very recently, and the grants that they've been able to access for people who are dying have halved and or even cut further. The reality is that the most vulnerable people in our society are feeling this squeeze, and I truly believe our sector is vital in that. I think in the past there's been a tokenistic approach to how we are supportive, etc., but also not a necessary recognition that we are a professional sector as well. So volunteering is a professional way of dealing with things. Our organisations are professional organisations, and your support in those conversations with others is incredibly challenging. And I think long-term health and care, the system does need to recognise without our sector it would crumble. And I think that's probably some of the stuff that we're talking about. The church sector does an amazing job, but we know that they need some support. And actually, it doesn't take a huge amount of investment to make a massive difference to some of these groups. We're not talking a huge amount, but it is vital. So that's my response. Paul, I don't know if you want to add.
Yeah, I would echo pretty much what you're saying, Chris. And I think actually, one of the biggest things you can do is, as councillors, is recognise the importance of the physical and social infrastructure that's required by voluntary community, faith and social enterprise organisations. And I think, as Chris says, the majority of our members have incomes they are small. They are less than £100,000 a year, and actually, in truth, probably many of those are less than £20,000 a year. So small investment actually goes a long way, and recognising that is important for those community and volunteer-led organisations, but also recognising and supporting the professionalism that comes from those larger community and voluntary sector organisations such as Mind, St Barnabas, Age UK, Lives, all those organisations that actually make a massive contribution to our community lives, but also our population's health and well-being.
Okay, thank you. Any other speakers? No, I've just got two more questions on myself. And one of those is I would like to raise a specific issue which has been raised previously at this committee. Because of the rural nature of the county and the distances many people have to travel for treatment, volunteer car schemes provide transport for patients to and from hospitals. Are there any volunteer car schemes in LVET's membership?
Yes, so the volunteer car scheme in Lincoln is in our membership. the challenge is that, as you say, as a large rural county, actually those volunteer transport programs across other parts of the county are not as well developed.
Okay, thank you.
Sorry, Chair.
Chris,
Can I
yes,
just
sir.
add one? Sorry, just one comment on that, and it's just, and again, it's parochial to St Barnabas, but I wanted to raise is that the last 2 years we have had more and more feedback in my sort of the welfare rights team that actually people are making decisions about their treatment and ending their treatment on the basis of transport and cost to get to venues, and in very practical terms that does mean people are potentially ending their lives earlier than they could be. So your question is very, very pertinent, and it's life-changing for some people. So,
Thank you. My final question is, I want to thank you for all the information presented. Are you able to suggest any other general or specific organisations that would provide the committee with further insight into the work of the volunteer sector in Lincolnshire?
I'm sure we could. There'd be plenty of members of different sizes and organisations that would be willing and very happy to come and talk to the committee. Actually, so yeah, that would not be a problem, and we can talk about that certainly.
Yeah, I think that'd be really useful. I'm sure Simon will be able to have that conversation back and forth. Councillor McGee.
Potentially VCS and now LCBS, I believe they've merged, haven't they, would probably be a great organisation to have in. They have quarterly forums and things where any of us can attend to see what's going on in our area, and they run the social prescribing programme. I'm looking at their volunteer website, which I know has been up and running since last year. It's excellent. And it also has young people's opportunities on there, which is really important for people going to college and things. So potentially Ben from VCS would be a great person to have in and come and talk to us.
Yeah, I mean, that's incredibly useful. Thank you.
Absolutely. I would just say, so the Lincolnshire Volunteer Programme that you just mentioned there, that is the programme that we've worked with LCBS and VCS to implement and jointly manage, and we work very closely with Ben, and so yeah, absolutely agree. It's a great person to have in to talk to. Yeah.
Thank you, and of course it goes to the committee as well. Thank you to Councillor McGee for her suggestion, but if any other members have suggestions, please do feed them in to Simon as well, and we'll certainly consider it, because I do think, there is a larger piece of work there. This is an overview, but looking into the more in-depth pockets is something that's becoming more and more important to be looking into, so thank you. Okay, at which point I'm now going to bring the debate to a close, and I'd like to thank the presenters from the Lincolnshire Voluntary Engagement Team for presenting to the committee, to record the committee's gratitude for the work of all voluntary, charity and community interest organisations supporting the health service in Lincolnshire, including all the volunteers giving their own time for this role. Do I have a seconder for my proposal? Thank you, Councillor Kendrick. And all those in favour, please show. Thank you. That's supported unanimously. And once again, thank you to our presenters.
thank you, time.
Thank you.
Thank you. Unfortunately, we can't move on to agenda item 7 before midday because our presenters are not available. So what I'm going to suggest is that we move on to agenda item 8, followed by 9, and then we'll jump back. So, Simon.
Thank you, Chairman. So on page 45 is the report on the quality accounts. Several members of the committee who've been around for a few years will know that this is something that I run through the committee every March in order to make arrangements for the quality account process. So what is a quality account? Basically, each provider who meets a certain threshold is required to prepare a document called a quality account each year. And the documents are typically between 70 to 120 pages, and they have to follow a prescribed content from NHS England. And the point about a quality account, it is an account of the quality of service provided by the trust, not an account of the finances that kind of stuff is in other documents, usually their annual report. So it's really, the term ever since it was invented has always caused a certain amount of confusion. It's just really an account of the quality of the service provided. So each year the provider trusts prepare their draft accounts, and as is stated in the report, they're required to circulate them in draft to the local overview and scrutiny committees, the local health watch organisation, and the relevant integrated care board. It says clinical commissioning group there, and I apologise for that error. Obviously last year's report and probably the year before has not been changed, but anyway, it's the so there is a requirement that they come in draft, and then the committee, and in effect the way it operates here is via a working group which meets now meets on Teams, has an opportunity to ask questions from the provider and then prepare a statement which, in the sort of rules on this, regulations on this, can be up to 1,000 words. So the first part of the committee's, the first question for the committee today is which providers the committee would like to consider. It's not a duty on the committee. It is a, if you like, a power. It's something the committee can opt to do. So if we look at page 47, the committee did 4 statements last year: EMAS, LCHS, Northern Lincolnshire and Goole, and United Lincolnshire Hospitals. So it's really a matter for the committee. Now, to aid the committee in doing that, I have included in the 2 appendices a summary in the first appendix of the priorities for improvement that the trusts included last year. So that's a big required element of the quality account. This is the things we're going to improve in terms of quality in the coming year. And I've also added in the second appendix B a sort of an overall ratings from the CQC. Now that is kind of raises another separate issue, because a number of those ratings are from quite a long time ago, like 2018, for example, in the case of one trust. Now that's not, there are specific reasons for that. The CQC obviously during the pandemic had a very, well, I suppose for the best part of 2 years, it had a very sort of passive role in terms of its regulation. And then since then, it's been introducing and is currently introducing a new inspection regime. And this means that the days of large numbers of inspectors, for example, arriving at Lincoln County Hospital, say, or Pilgrim Hospital on a given day are over. Sort of 50 or 60 inspectors or whatever all turning up on one day, those days are gone, and it's a much more focused inspections. Now that process will feed into the overall rating, but I think is going to be a much slower process as the new regime beds in. Sorry to go on that little digression. So using the CQC rating and using the priorities for improvement, the first question for the committee would be which providers the committee would like or thinks it's appropriate to make a statement on. And then I suppose the second thing is the members of the committee who would like to come forward either to sit on all the working group meetings or those for specific providers. That, I think, I should just add that although the documents are 70, 80, whatever, 120 pages long, there are specific parts of the document that the working group usually needs to focus on, and these are the priorities improvement that are planned for the coming year and the progress on the priorities for improvement of the last year. Although there are large elements of the document on, for example, clinical audits, which are generally, 30 or 40 pages, which are exceptionally detailed, and it's not necessary to go through that page by page. I hope I've not left anyone with any more confused than they were when they read it. But basically, the first question is, what providers would the committee feel they would like to make a statement on this year? And then it's a case of volunteers to join a group. Thank you. Thank you, Chairman.
Thank you, Simon, and it's as glamorous as Simon's made it out to be. So, the one thing I would say is, as has been alluded to within the report, you do have the other health scrutiny committees across the region looking at places such as North Lincolnshire and Goole, North West Anglia, and so we have always, you know, traditionally sort of stood away from there, though we did look at MWAF last year. I mean, personally, if I was to put anything forward, I think the fact that, you know, United Lincolnshire Hospitals Trust still remains as requires improvement, I think that's one that we should be definitely looking at. And I think EMAS being such a large service, and although it is rated good, it's not always necessarily a good service that's in, you know, Lincolnshire or our part of Lincolnshire. So that would be my two suggestions, but I'm open to the committee for any other views. Councillor Smith, please.
Thank you, Chairman. I take your point around North Links and Goole that you raised, but as per what I raised at the start of the meeting, I think it would be, given what's going on there at present, I think that could be one that's prudent to, shall I say, cast our eyes over for that very reason. And the other one that sort of caught my attention was LPFT as well, because similarly to EMAS, we hear contradicting things, and although some parts of it are good, some parts of it we know there are issues with. So that they would be my two suggestions as well, Chairman.
Okay. Councillor McGee?
Yeah, I'd concur that LPFT potentially needs a little bit of a look from us.
Okay, any other comments, please? No? Yeah, Councillor Morgan?
I might be completely in the wrong ballpark here. It does seem to me for continuity, if it makes sense to look at what we looked at before, so we're carrying it forward. It does seem to me logical to do that. So we had LCHS in there last time, and I don't know how we feel about that now. And I have a question, and that's about the ICB. We've got this new organisation. I don't know if this is the place to look at this.
No, they don't do quality accounts. It's not part of what they have to, within legislation, provide.
Is it something then we could perhaps look at separately or put forward to examine?
No, it's not, unfortunately. It's not something that would come under this remit. We do, of course, have the ICB come and present to us on varying different parts of the service they provide, but I will bring Simon in just to clarify further.
Yeah, I mean, the role is really a focus on the quality accounts are a requirement of providers. So the ICB as a commissioner is not required to, I mean, they are in turn monitored separately by NHS England. So there are processes of that. But the reason that the committee focuses on the quality accounts is that there is specific regulations enabling the committee to do so. And it is something for providers, but as has been previously pointed out, it's not all providers. So, for example, GP services are specifically excluded, and I'm not sure the committee would want to go through 81. Is it? Yes, 81 GP. Anyway, that's but GPs are specifically excluded as well. Thank you.
People feel about LCHS.
The one thing I would say is whatever you want to go forwards with, if you've put it forwards, I would suggest that you're on that committee for the working group, because you are talking about, we've now got 5 that have been requested. You're going to be talking about 500-600 pages you're going to have to read through, and then you will have to, I would say, if you've put it forwards, I would always recommend that you take part in the working group, because it has traditionally always been myself, Linda, and Ray, you know. So it hasn't tended to be many other members, and though I'm more than willing to look over it, I think if you put it forward, you should probably put yourself forward. So, you know, if that's what the committee want to do, and they're the ones that they want to take forward, we're looking at EMAS, LCHS, LPFT, NLAG, and I think you suggested NWAFT as well, Councillor Morgan, and United Lincolnshire Hospitals Trust. So the only one we won't be looking at is St Barnabas. So, yeah, Liz.
It was just a suggestion, and I know we're kind of separate organisations, but as Simon said, Health Watch do also have an overview and scrutiny. So I wonder whether we might be able to pick up the ones, so we could almost overview the whole lot between ourselves in terms of Health Scrutiny taking a lead on 4 and perhaps Health Watch taking a lead on the others might be a good way of covering everything, or the lead ones. Maybe that's something, Simon, I could just liaise with you about.
Yeah, that's fine. I mean, I think we can certainly record. I mean, so we've got 6 listed as the committee's preference. And are there any of those that the committee, having expressed a preference, would put in a higher category, for example, ULHT, or is it? Yeah.
Yeah, I think ULHT and EMAS are certainly, I would say, the top priorities. The fact that LCHS is still outstanding, perhaps that might be one that perhaps...
And so, for example, NLAG would be covered by the Health Watches in North and North East Lincolnshire.
As well.
And North West Anglia would be by the Cambridge and Peterborough Health Watches. So really that would just leave LPFT and LCHS. Anyway, we can perhaps, yeah. So we've got a top 2 and then another 4 that are potential. If that makes sense.
That's, I think, where we are at the moment, Simon. Thank you. Yeah, Councillor McGee?
Can I ask about time commitments or arrangements for a working group? Sorry. It's fine.
Committee chairman at the same time, apologies.
Time commitments and arrangements for the working group. Obviously, I work part-time. I'd be interested, but it's just the level of commitment.
Yeah, thank you, Councillor McGee. Normally what we'll do is we'll do the quality accounts in one meeting. We normally go through it, and at the end we'll come up with our suggestions. Then Simon does the legwork, bless him. And then so it would just be the reading in advance, and then one for each of those particular ones we'd be looking at for about, what is it, 2 hours normally, give or take?
Yeah, it's possibly an hour per item. So sometimes I try and double them up so that we're doing 2 in a session. But the meetings are, you know, they're over Teams, so it is an informal. You know, it's not coming in here or anywhere else.
If it could be around my working arrangements, I'd be interested.
Thank you.
Thank you. And you down, Councillor Morgan and Councillor. I've got Councillor Parkin first because I've allowed you in once already, Councillor Morgan.
Kind of similar point, really. If we can arrange it so that they don't clash with the district, as for some of us from the districts, our other commitment meeting-wise, I'll be happy to volunteer.
Well, note your name down, thank you. Councillor Parkin.
I really like the idea of sharing the workload and sharing the scrutiny. I do think, though, that once we've shared the workload, we need to share the results. Yeah, and so we would need to come up with some mechanism of cross-pollination, or whatever we would call it, in terms of where we then look. But also, I think we then need to be very, very clear moving forward how that informs our work programme from there. Because I sometimes think that this is all like catching sand, isn't it? And we're spinning plates all of the time. So I think we then need to be really, really clear where our focuses are. I do agree, particularly with the Hospital Trust and EMAS contributions. I think it's really, really important. I think of all the plates that we're trying to spin, they're probably the 2 biggies at the moment, certainly in terms of how it's impacting residents.
Absolutely, fully agree, Councillor Parkin. Councillor Smith.
Thank you, Chairman. In terms of LPFT and NLAG, I'm quite happy to volunteer as I put them forward. As from my previous comments, Chairman, I think NLAG is becoming increasingly important that we as a scrutiny committee look at due to what they're proposing to do and change. And okay, it might not be this time round necessarily that it impacts, but it's sort of giving them a warning shot to say, we are looking, we will continue to look, because we know there's problems already, Chairman. Let's be honest, we're not going to beat around the bush. There are problems already, and I suspect they're only going to intensify. So I think it's prudent to do, and I'm quite happy to volunteer.
Yeah, I mean, I would just sort of say it's more about what their priorities are moving forwards, and of course, any changes, you know, like we were seeing over in that way, they do come to this committee. We've had them at this committee, and we've formed part of the joint health and overview committee of that. But absolutely, Liz.
Sorry, not to labour a point, and obviously we'd be willing to share the findings, but we tend to, I don't know whether you do this, Simon, we tend to have a presentation from the organisation and then a discussion and the report. So we actually have them online sharing the quality account with us, so we can have some direct confirm and challenge with the organisation.
Yeah, it's what we try and do. I think last year there was a couple that we didn't have attendees actually from there, but in the main, ULH always sends someone. I think EMAS
EMAS is more difficult because there are quite a large, I think it's now 11 scrutiny committees across the region. So yeah, thank you.
Thank you. And obviously I'll put myself forward. And Linda, so we'll be on those as well, Simon, as ever. Okay, thank you. I think we've got a way forward with that anyway, so I think we're all agreed in the May that we'll move on. Thank you. Have we got our presenters now, Simon? So we'll come back to the work programme at the end as traditionally, and we'll move into the presentation for everyone. Let me just get organised to jump back to where we were. Okay, then, in which case I'd like to move on to agenda item 7, North West Anglia NHS Foundations Trust. This item was circulated as part of the agenda pack on pages 39 to 43. Each year, the committee receives an update from North West Anglia NHS Foundation Trust, in particular focusing on Stamford Hospital. The last update was in January 2023, and I would like to welcome our presenters on Teams, Hannah Coffey, Chief Executive, and David Moss, Director of Estates and Facilities. If I can just give you 5 or 10 minutes just to run through the report and take questions at the end, please. Thank you.
Hello, thank you, Councillor Macy. Hello, everybody. I can't quite see anybody, so apologies. My name's Hannah Coffey. I'm the Chief Exec of North West Anglia, which obviously includes Peterborough Hospital and Stamford, for which I know a significant number of residents of Lincolnshire, 160,000 in fact, use our facilities. Well, I don't know whether I'm relatively new in post now, because I've been in post for 6 months, so it kind of depends. But I've had a really great introduction to the organisation, and I thought I've got Callum here, who's our Chief Medical Officer, who's the lead for the Stamford project. So I'll get Callum just to briefly outline a little bit on that. But if I do just a very quick, broader, what have I seen, what we're doing, and some of the challenges, I think, and then I'll hand over to Callum, and obviously David's here if he wants to take any specific questions on the Stamford redevelopment. So from my perspective, clearly we have it's a pretty big organisation, and given the audience, obviously, as I've said, a significant proportion of our patient flows come from Lincolnshire, 160,000, about 20% of our activity. So a really important commitment to you and to your population. And I have had a number of conversations with John Turner as the Chief Executive of the ICB to ensure that we have good, strong relationships, which I know are a feature of the work between Lincolnshire and North West Anglia Trust. So what I would say, and I'm sure these will be features of what your residents are saying to you, we have, particularly on the Peterborough site, had some particular challenges around emergency department performance and ambulance handover times, and I'm also aware that EMAS that we do receive from EMAS, and they've obviously been very challenged organisation. I know that they're on national monitoring at the moment, and we try our best, and I'll talk to you a little bit about what we're doing to try and make sure that we maintain flow so that ambulances can be freed up to get to the serious incidents. So since I've been in, we've made some significant improvements, and thanks to the whole team on that. We've got a programme which is referenced in the paper called Back on Track, and I just want to very quickly pause on what that's about. So really about focusing on the key indicators of quality and safety for our patients, and also for the experience of our staff as well. And as you'll be well aware, there's a very direct link between experience of staff and the outcomes for patients. So we're doing both of those things. And what we're trying to do is have an improvement approach to the work. Firstly, because we have to sustain it. I think one of the challenges in the past has been that we're pretty good at focusing on one thing and improving it, but we need to be able to sustain it across a number of areas. and also because the evidence suggests that really high quality, highly performing organisations where there are good outcomes and also really great staff experience are about focusing on giving people autonomy, data, visible, connected leadership, and trying to ensure that the staff who know what the solutions are empowered to make those solutions. And that's been the approach. We have a number of huddles. We do a daily one, and you'll see from the paper again that is about bringing teams together face to face to resolve issues in real time and work across the organisation to do that. So that is the premise of it, and that's why the evidence suggests that doing this both sustains performance, but importantly, if you look at our staff survey and you look at some of the challenges we have to really address this more sustainably. So what we can see is a significant reduction in our ambulance handover times. That has meant, and we've been very clear in our public board, we've done a number of organisations have also done, which is we have shifted some of the risk from the front door into the ED department and onto our wards. So we do have, although that is reducing, what we call boarding, which is where we have patients on our wards where we do not have a bed space for them. We have up to 2 on some of our wards at any one time. We try to ensure that they are the lowest risk and often people who are going home that day, but we are really clear and recognise that is not a great experience for patients. We've talked about it at board, we've had patient stories, and the Back on Track programme is really about eliminating that. But we've done what a number of organisations have done, which is essentially about trying to move the risk so that we can free up ambulances to turn them around so they can get back out to the critical emergencies. So it's about spreading the risk across the system. And as a consequence, as a consequence of that and many other things, we've seen a significant reduction in our handover times, an improvement in our emergency performance of 4 hours. We're probably about mid-table now, Midlands and East. We've been at the very bottom, so we're demonstrating good progress, but we have high aspirations. And then in terms of cancer and elective weights, which are, I guess, other areas in terms of people being economically free and able to go about their lives, but also about dealing with weights when you're very worried, we can see a significant reduction now in our patients waiting over 62 days for cancer, and some really good improvements in faster diagnosis, as well as being in a situation where we'll have a handful of patients at the end of this month who've been waiting 78 weeks, and we continue to move that down to 65 and 52. So whilst there's a huge way to go, I think what I'm trying to describe to you is an approach around how we take an organisation forward in positively and demonstrating that we can make change even during a very, very challenging time in the organisation. So the huddles happen at Stamford. They happen, we have, as an executive team, we meet with our teams every day. And obviously, within the paper, we talk about some of how that is translating into the services that we have at Stamford as well. So I'll probably leave it there in terms of what's important, what we've been doing, and also just reinforcing our commitment to your residents and the issues that are, I would suggest at the moment, probably most affecting them in terms of their access to healthcare at our organisations. I'll be in your hands if you want to. Should we just quickly move on to Stamford and then people can ask questions? Is that okay, Councillor Macy?
Yeah, that works fine for me. Thank you.
Yep. Okay, I'll just hand over to Callum then, who is our executive lead and also our chief medical officer for the Stamford redevelopment.
Thank you, Hannah. As Hannah says, we do now do huddles at Stamford, and in fact, I'm doing I think it's their second huddle on Monday morning. So it's a real privilege, really, for me to be the exec lead for Stamford redevelopment. It absolutely has been clinically led, but with fantastic input from Estates and Facilities colleagues. And of course, we've got David as Director of Estates and Facilities for the Trust present today. One of our key things has been really around maximising the space that we have at Stamford to maximise the local offering to our population. So you'll see within section 2 of the report, really trying to offer more day case local anaesthetic procedures, doing chemotherapy and things like intravenous therapies at Stamford, which we haven't done before, really to try and make sure that the offering that we give to the local populace is even more than it has been in the past. One of the things that we've got within the current Stamford building is we do have in the current day treatment unit called the Johnfield Suite, and that is made up of what I'm sure you've read on the news is rack concrete. So this is this weakened aerated concrete that does, and all those buildings need to be replaced. So we have secured a significant amount of national funding to be able to build a new day treatment unit, obviously subject to appropriate planning approval, which we hope to gain this coming May. That will then allow us to knock down the old Dronfield Suite and the adjacent ward that supports that. Within the day treatment unit, again, we're looking to see how we can not just replace like for like, but absolutely maximise the new day treatment unit so that we can see even more patients through the doors for the local population for local anaesthetic procedures. So it's a really, really exciting opportunity for us as a trust, but also our local population. And of course, Friends of Stamford and many stakeholders have been involved in the project board, which I chair, and in a number of the conversations and updates that we've given in terms of evening open days and so forth to give the local colleagues updates in terms of where we are. And the final bit I was just going to draw attention to is the sale of the unused land. So we've got 3 pieces of land that are surplus to requirement. That is in the process of going through as we speak. The one thing that I would say is that we are keen to continue to work with the buyer and the civic society and the local authority to look at options around things like museums on site and so forth. So, you know, again, really keen to make sure that our offering to the local population is as good as it can be, and engaging in those conversations. I won't say obviously any more than that until the sale goes through, but happy to stop there and take any questions.
Okay, thank you for that. I've got Councillor Morgan first, please.
I feel I ought to declare an interest in that I'm actually the Vice Chair of Planning at South Kesteven District Council. So obviously this will be coming up before us. So I'm actually going to reserve any comments because of that.
Okay, thank you, Councillor Morgan. Councillor Dilks.
Good morning, or afternoon. Similarly, I'm Cabinet Member for Planning on South Kesteven, but I don't believe that anything affects me here, but I just mentioned that. I'm actually substituting today for my colleague Councillor Cleaver, a Stamford councillor. I personally, I'm a user of Stamford Hospital, have been in the past. And he's asked me to raise a couple of questions with you, having read the papers. And the first one is, some years ago, there was a recognition of the need for more car parking for patients at Stamford Hospital, and to the extent that planning permission was granted for extra parking within the complex. But that hasn't happened over the years, and I believe that the planning permission has now lapsed. So can I ask, on behalf of my colleague, why is it no longer a priority, parking, and what steps are you able to take to enforce the fact that only patients, getting treatment at the time should be using the parking there? Because I understand others sort of park there and leave the cars there for long periods. That's the first point. Do you want me to go on to the others, Chairman? I've got 2 others.
I think if we allow the presenters to come back to you, and then if you ask your questions for a moment.
Thank you.
So did you want me to start off and then you come in, David, or do you want to answer that one?
Sure, no, Callum, you start off and I'll come in.
So thank you, David. So first thing to say is that absolutely remains a priority for us. We know that it is a challenge at certain peak times for our patients and visitors to be able to park at Stamford. Some of that is as a consequence of some of the nearby companies and facilities not introducing ANPR, so that they have been charging people to park where they are, including around the local GP practice. So we will be introducing ANPR so that only appropriate patients and visitors will be able to park in our grounds moving forward. You're absolutely right. We did have planning permission previously for a multi-storey car park, and of course, whilst that remains a consideration were that to be required, we of course need to utilise public funds appropriately, and if there are alternatives to not building a multi-storey car park, including conversations that are ongoing that David may be able to touch on with one of the adjacent large car parks, which might mean that we can still provide sufficient space for our patients and staff without the need for a multi-storey car park. David, did you want to come in on that?
Yes, certainly. Thank you, Callum. So as you can imagine, car parking at hospitals is an emotive issue that we deal with all the time. And one of our primary goals has been for ensuring our staff travel as sustainably as possible, because we can get more of our staff using buses, or potentially cycling and walking to work, and that frees up more space for patients that need it. And we have done so certainly at Peterborough and Hinchinbrook with initiatives around free bus travel, and hope we are able to mirror something as well for staff working at Stamford. It's just a different area that we're working on. So that's the first aim, to ensure that the parking we do have is used and we meet our sustainability objectives. As Callum said, we've invested in parking controls, so they will be implemented in the spring. So we're going to effectively have the ability to control who parks there, which we don't have at present, which causes some of the issues because we have non-patients and staff using the facilities. But we're also undertaking, across all three of our hospitals, things like travel plans that work on, assessing how we can improve travel to the hospitals. But the strategy really is about ensuring that, the patients that need parking close to the hospital most of all for mobility challenges, etc., have that facility, and we encourage other people that can to travel there sustainably.
I'm grateful for the answers, thank you, and I'm sure I'll pass them to Councillor Cleaver. My next question was on. I noticed that the minor injuries unit at Stamford was notable by its absence in the papers promoting the daycare, the day treatment centre. Can you please clarify the position on the future of the minor injuries unit? And just as a final question, I'll throw in now because I think it's a quick one, is you're obviously seeking planning permission in May, but have a target of the day treatment centre, a new build, being open early 25. That just sounds a little bit of a big ask. Is it realistic? Thank you.
Thank you. Should we cover off the planning permission first, and then we'll come back to the MIU?
Yes, certainly. So I can cover the planning permission. So effectively what we're doing is a modular build. So a lot of it is constructed off-site, delivered in modules, and therefore we have a very condensed window of construction. It's what's known as modern methods of construction, and it's something that is quite well established across the NHS. So the planning permission, we have a lot of confidence because, this is replacing a RAC building, which has inherent risk, and there's also a commitment from the government to replace RAC buildings. And hopefully you've seen from paper that this is both a significant investment at sort of £18 million, but also perhaps the biggest investment that we've had in Stamford itself. So it will be improving the buildings and the care that we can give. So we are reasonably confident that it will be passed, and yes, the window is one that we can achieve and have previous experience of doing so. So January 25 is a realistic date.
Thank you. David, so in relation to the MIU, so you'll be aware, I would expect, that the guidance around the provision of MIUs has changed as a national guidance change. and that is a commissioned service. So I can't comment in relation to the commissioning because that needs to be with John Turner as the ICB. All I would say is we know it's an issue and we are working very closely with the ICB to try and find a way through what is clear guidance to ensure that we can maintain services in Stamford, because as we have said and what have I said, we have a responsibility to the citizens of Stamford to provide that service. So in terms of intent, that's with the commissioners. I'm sure you'll pick up with that with them separately, but what we are keen to find a pragmatic solution.
Thank you very much. Thank you.
Thank you. I would just add that the UTC item we have got coming forward anyway, and it is something that is on the work programme, so we will speak to the commissioners in terms of that, though I don't think they're clear yet themselves on what way they're going to move forward with it. So, but thank you. Do I have any other questions, please? No? Okay. There's just the one I have then, in which case, and that is, are you expecting any developments or service changes at the Peterborough City Hospital site in the next year or so?
Not that I'm aware of, but we're just going through our annual planning, and obviously we recognise that we have a statutory responsibility to consult on that. So from that perspective, David or Callum may want to comment. David, no?
Yes, so I would just add, obviously, we've got some construction works ongoing at Peterborough at the present time. So we're in construction with a 20-bed modular ward, which will complete in June. And we're going to be also adding 2 additional wards, both of 36 beds, which is through conversion of existing office space into clinical space. So in total, we should have an additional up to 92 beds.
Excellent, thank you. I think the committee are always nervous currently with acute services continuously changing across the region, so that's where our questions
Of course, no, I
from.
completely understand, but I am very clear about the responsibilities around consultation, so we'll obviously keep you updated if there are any changes that we are starting to look at. The other thing I would just, a very warm kind of invitation to you all to come and visit, not just Stamford, but Peterborough. I'm used to hosting visits with my Scrutiny chairs and teams. I think it would be great if you have the time and the opportunity to come and have a look around and see what we're doing.
Thank you. We appreciate that offer very much. Councillor Morgan, you've just come in with an additional question.
Thank you. Apologies. It's a different hat, not Stamford, Peterborough. First of all, I'd just like to give some feedback. Unfortunately, a family member had to have mental health emergency visit to Peterborough, and I'd just like to say the service that was received, despite the fact that the A&E department was overflowing, was absolutely amazing. So I'd just like to sincere thanks to everyone involved there. It was somebody aged 17 who got taken to the children's ward and was dealt with really, really professionally and sympathetically, despite how busy they were. The point then, going back to the point that was made, with changes to the acute services in Lincolnshire and with Grantham and the changes downgrade of our A&E, I did do a Freedom of Information request and was advised that your trust was not consulted regarding the potential impacts on your A&E with regards to the changes at Grantham. And I just wondered if you've had any overall impression whether it has affected you over the last year, if you've seen any increases in patients to your A&E. Thank you.
Thank you. Obviously, I can't comment because this would have been before my time in terms of process. I mean, we're seeing a relatively stable number of ED attendances at the moment. We haven't seen anything significant. What we haven't done is analyse changes in patient flows, which we could do if necessary. But certainly, we see a pretty steady attendances at the trust.
Thank you. Yeah, Councillor Morgan, I will say that at the time of the acute services review, this question was asked of what was prior to the ICB, ICS, and we were told absolutely those conversations had taken place, and we were also told by the previous chief executive of NWAF that these conversations had taken place. So I don't want to put ourselves in an awkward position. I'm not saying that your Freedom of Information Act is not correct in what it's saying, but that's certainly not the feedback we were given. And, live in these meetings, we were told specifically those conversations took place across the trusts.
I was also told that by ULHT and other key decision makers at the time, but I was concerned because their report did not include Peterborough. In fact, in the final report, which is why I put the FOI request in.
Okay, thank you. I'm sure we can look at flow numbers next time when we have the presentation next year from MWAFT. But I'd like to say thank you very much for your attendance at today's meeting. I'd like to propose we fully support and welcome the plans for a new day case treatment centre at Stamford and Rutland Hospital, and to seek a further update in 1 year's time with flows within there and a little bit more, I think, on Peterborough, so that we've got a more rounded view. But do I have a seconder for that proposal? Thank you, Councillor Smith. All those in favour, please show. That's supported unanimously. And once again, thanks to our presenters. We'll see you in a year's time, and the best of luck. Thank you.
Thank you very much.
Thank you very much. Bye.
Have a good day.
And
Bye-bye.
you. Bye-bye. We'll now move on to agenda item 9, the work programme. Simon, I'll hand over to you.
Thank you. Thank you, Chairman. I apologise that I always seem to be reporting on changes to the work programme and that things aren't quite as we expected. So the first change is that we're bringing forward from the 17th of July the item on GP provision. So this is now coming in on the 15th of May. This is all to do with availability, and I do appreciate that that means that it's not quite 6 months since the last one was in December, so it is quicker than 6 months. But I think there are a number of things going on with GP services that merit that thing. It's all to do with presenter availability rather than putting it back into the autumn. The other thing, going to Chris Higgins's presentation, the number 3 on the list for July, I think Chris mentioned, and I will need to check this, that it was likely that the Manthorpe and the service would be dealt with, would be something coming forward in September, but I will need to check that one. And the other thing, going to next month's meeting, is that number 2 on the list says the outcomes of the review of urgent treatment centres. I've been advised that the review of urgent treatment centres has not or will not be ready by the 17th of April, but there will be information on the operation of urgent treatment centres. That does exclude Grantham, because Grantham has got its own specific item, which is coming forward on the 12th of June to cover the first 6 months or so of the urgent treatment centre at Grantham. Just going back to the, sorry to prolong this, but just going back to the discussion with the voluntary Lincolnshire voluntary engagement team, I think there were a couple of things, because there are, if there are other organisations, I mean, I've already got one suggestion, but if there are other organisations, I can perhaps look at maybe if the committee wishes to schedule those. But there was one particular thing, which was the funding, when LVET said they themselves can't get that information. I mean, there are ways, it sounds like it's very sinister, because if you look on the website of an ICB, you can look at their expenditure. Each month they're required to list all their expenditure over £25,000, but that doesn't necessarily mean what it's for. It just has a list of an organisation and how much they've received that particular month. It doesn't really tell you anything else other than that. But that is maybe something that we could maybe pursue if the committee wished to look at that from the, if you like, the ICB's point of view of the voluntary sector. That's just a suggestion which I'm just putting forward. Thank you, Chairman.
Thank you, Simon. Yeah, I think I'd certainly support that moving forward. I think it's something that would be of interest to the committee. I'm seeing nodding heads, so I think we'll certainly add that to the work programme. Do I have any other comments on the work programme moving forward? No. Okay. In which case, Councillor Morgan.
I just wanted to say thank you for adding, well, the cancer care, because this came up at the patient, with the patient forum. There have some issues around that, so thank you. That's good it's in there.
No problem. Thank you. We do have it as a regular item and that's on the agenda anyway, so, but no problem. Okay, if we're all happy with the work programme, just a show of hands that we move forward. Thank you. Yeah, that's supported. In which case, I'll bring the meeting to a close, and I'd like to thank you all for your participation today. Thank you.